This is part 2 of the lecture on imaging the paranasal sinuses. We've gone through modalities and anatomy. We're going to talk now more about the pterygopalatine fossa and some normal variants that we encounter. Let's take a little bit of time to talk about the anatomy of the pterygopalatine fossa. It's complex stuff, but it's really important when we're talking about perineural spread of disease. Also, I wasn't sure where in the lecture series to put the discussion of the pterygopalatine fossa, and this seems like the appropriate location when we're talking about the anatomy of the paranasal sinuses. The major inhabitant of the pterygopalatine fossa is the pterygopalatine ganglion. The pterygopalatine ganglion forms from Vidian's nerve as it comes through Vidian's canal. It's a branch of the 7th cranial nerve and comes through Vidian's canal and then dead ends directly into the pterygopalatine ganglion. In the same vicinity, the second branch of the 5th cranial nerve, V2, is coming by too, but it's coming superior to the pterygopalatine ganglion. It's just visiting, like in Monopoly. It sends a few feelers down to the pterygopalatine ganglion, gets some feelers back, so there is some communication there, but it's going straight over top of the pterygopalatine ganglion and continuing on to become the infraorbital nerve. One of the most important things to understand about the pterygopalatine fossa with respect to imaging is that it is predominantly composed of fat. Yes, there's a ganglion and nerves in there. Yes, there's a sphenopalatine artery and some accompanying veins running through there. But the dominant thing that you find in the pterygopalatine fossa is fat, and we're going to use that fat to our advantage on imaging. The entrances and exits from the pterygopalatine fossa are complex. On the medial aspect of the pterygopalatine fossa, there is a sphenopalatine foramen that communicates into the nasal cavity. On the lateral aspect of the pterygopalatine fossa, there is a pterygomaxillary fissure that communicates into the infratemporal fossa. I know this sounds like a little bit of a word salad. We're just throwing letters together, but I'll show you some examples and hopefully it'll all come together. Here is an axial CT image of the pterygopalatine fossa. Note that it is predominantly composed of fat. There's other stuff in here too, but it is predominantly composed of fat. That's what we're looking for. If you want to find the pterygopalatine fossa, go to the center of the maxillary sinus and look right behind it. So it's right behind the center of the maxillary sinus. That's your pterygopalatine fossa. Here's the same concept on a T1 weighted unenhanced MR. I chose T1 weighted unenhanced without fat suppression because I wanted to point out that the dominant signal in the pterygopalatine fossa is the fat. It's bright like all the other fat. That's what we want to see is fat in the pterygopalatine fossa. Here's an example of how we can use that to our advantage, right? In this pterygopalatine fossa, there's the expected fat. There's also the sphenopalatine artery running through there, okay? But on this side, all that fat has been replaced. This happens to be perineural spread of tumor. Infection could have a very similar appearance, but this is how that fat can be useful to us radiologically. Even in patients who have terrible scans. This is an example of somebody with a lot of motion artifact. We couldn't even get to the post-contrast sequences. They said, is there any perineural spread in this patient? It's going to be tough with this quality of imaging. But look, here is the normal fat in the pterygopalatine fossa, and it is obliterated on this side. Yeah, there's perineural spread here. It has this tumor has completely filled the pterygopalatine fossa, and we can make that distinction even on images of this quality. Okay, so let's talk about some of the surrounding structures around the pterygopalatine fossa. I've switched to a coronal plane. Here's the pterygopalatine fossa in the coronal plane. We are right above the pterygoid plates. We're right behind the maxillary sinuses, but you can't see them because they're out of plane. So let's go over the word salad from that previous slide. If this is the pterygopalatine fossa, this gap right here that leads from the pterygopalatine fossa into the nasal cavity is the sphenopalatine foramen. And in fact, the sphenopalatine artery and veins are going to run right through there to feed the nasal mucosa. On the other side, on the lateral aspect of the pterygopalatine fossa, there's the pterygomaxillary fissure, and that is the opening into the infratemporal fossa, which is part of the masticator space. Below the pterygopalatine fossa are the pterygoid plates, medial and lateral pterygoid plates, and above it is the inferior orbital foramen. That is where V2 is running. So Vidian's nerve has dead-ended right into the pterygopalatine ganglion, but V2 is running above, just visiting, running above in that inferior orbital foramen. This image is one of the classic textbook images from head and neck radiology. This is one that you'll see on tests. This is a coronal image just posterior to the pterygopalatine fossa. And the reason that it is interesting is that it shows the nerves that are going to head in towards the pterygopalatine fossa. In particular, we're interested in this cross-sectional canal and this canal cotton cross-section. And the classic test question here is, which one of these is Vidian's canal and which one is V2, that is foramen rotundum, carrying the second branch of the fifth cranial nerve? Well, if you remember the anatomy we just talked about, Vidian's nerve needs to dead end into the pterygopalatine fossa, whereas V2 is just visiting over top of that. So the more superior and lateral one, that's V2. There's foramen rotundum, and the more inferior one is Vidian's canal, carrying Vidian's nerve, a branch of the seventh cranial nerve. The sphenoid sinuses have a variable relationship to these two structures. Sometimes they barely even reach these foramina. Sometimes the lateral recess of the sphenoid sinus will extend between them, and sometimes there's so much pneumatization of the sphenoid sinus that it looks like Vidian's canal is sitting on a little bony stalk floating in the middle of the sinus. All of those are normal variants on the sphenoid sinuses. But the teaching point here, foramen rotundum, Vidian's canal on this coronal image posterior to the pterygopalatine fossa. Let's look at those same canals on axial plane, right? I'm going to show you Vidian's canal and I'm going to show you foramen rotundum. Vidian's canal is long and thin and it leads right into the pterygopalatine fossa. So is this the pterygopalatine fossa? Yeah, we're right posterior to the center of the maxillary sinus. There's the pterygopalatine fossa, and leading right into it is this long, thin object. That is Vidian's canal. Here's another axial image, a little bit more superiorly. This short, blunt object, a little wider, that is foramen rotundum. It's carrying V2. Notice that it's not going into the pterygopalatine fossa. We're too high up here. We're going into the inferior orbital fissure right here. Okay. Don't forget, when you're imaging the paranasal sinuses and you're looking at all of these bony structures, don't forget that we sometimes run into soft tissue abnormalities that we only pick up. Even if you're using a low-dose technique, you're still responsible to have a look at these soft tissues and to find things like this hyperdense object. Remember, this is a non-con examination, so this is an intrinsically hyperdense object. Where are we here? Well, this is the tongue. This is actually really posterior. This is the base of tongue. Here's the uvula forming in the soft palate. Base of tongue, hyperdense, intrinsically hyperdense object. This is a lingual thyroid picked up on a sinus exam. When we're imaging the paranasal sinuses, we spend a lot of time looking for normal anatomic variants. If these are normal variants and they don't have clinical implications, why do we spend so much time on them? Because they can affect the endoscopic approach and can get in the way of endoscopic evaluation. So the normal variants that we're going to talk about are Concubilosa, paradoxical turbinates, septal deviations, and whenever we talk about the septal deviation, we always talk about spur, even if it's just to say there's no spur. It's got to be part of that conversation. Secondary ostia, asymmetric, anterior skull base, and Haller cells and its relatives, the Anodi cells and agarnesy cells. First off, note the correct pronunciation of this term. This is Concubilosa. Concubilosa is pneumatization of the middle turbinate. Sometimes ethmoid air cells occur inside the turbinate itself, and we refer to that as a concubilosa. These can have any of the spectrum of pathology we associate with other air cells. They can become entrapped and enlarged and infected, but you can see that they substantially widen the middle turbinate. Now, how much pneumatization counts as a concubilosa? I think you'll find different people have different opinions. Most authors want it to go at least 50% of the way from the skull base to the tip of the turbinate to be considered concubilosa. But really, anytime there's an air cell that can have pathology in there, it's probably worth mentioning. Notice the curve of the turbinates. They all curve under like a curled arm, and they curve towards the lateral wall. Every once in a while, though, you'll get a middle turbinate that curves the wrong way. This one's not curving in towards the lateral wall, it's curving towards the septum. That's called a paradoxical turbinate, and it's a normal variant, but worth mentioning. Septal deviation should be graded as mild, moderate, or severe, and it's quite subjective. Even small amounts of septal deviation should be addressed, however. I only say that the septum is midline when it is a perfectly straight line, straight up and down. You can talk about how the anterior aspect of the septum is mildly deviated. You can talk about how there's an S-shaped deviation where the superior convexity goes to the left. There's a lot of ways to talk about it, but any septal deviation really needs to be discussed and mentioned in the report. There are a couple of different types of spurs that occur in conjunction with septal deviation. One is a shelf-like spur, where the width of the spur does not change substantially from left to right. The other type of spur is a broad spur, a broad-based spur, where it is much wider against the septum than it is when it comes to a point. This distinction is important because they can be treated differently endoscopically. A shelf-like spur can be snapped off, whereas a broad spur requires more drilling. Another important thing to mention when you're talking about septal spurs is whether they contact other mucosal surfaces and whether they cause remodeling of other structures. For example, here, this spur contacts and deforms the middle turbinate. When two mucosal surfaces touch like this, it can cause pain, and that pain may mimic the pain of sinusitis, so this can be an extremely important finding. Secondary ostia. Sometimes there is an extra hole, particularly in the medial walls of the maxillary sinuses. This is not the osteomeatal complex. This is in a different location. It's just an extra hole. You'd think this would be really useful, and if you blocked your osteomeatal complex, you'd just roll over to your secondary ostium, and it would be a good backup. Turns out that they're less useful than you might imagine. All the cilia are still pushing the mucus towards that primary ostium, and so secondary ostia not as helpful as you might expect. Still worthy of mention. Symmetry in the nasal cavity roof is really important. You want to have cribriform plates that are symmetric, and you want to have fovea ethmoidalis that are symmetric. You can see in this case, the right fovea ethmoidalis is about 5 millimeters lower than the left. We want to talk about any asymmetries here. This is important surgically because if you put an endoscope up to this level on the left, and then you pull it out and set it up to put it up to that same level on the right, you're going to perforate the anterior skull base, and that's considered a poor clinical outcome. Another important thing to discuss is how shallow or deep the cribriform plates are. That is, how much distance is there in the lateral lamella. You can see on this side there's essentially no lateral lamella, so that's a shallow cribriform plate. How shallow does it need to be? Well, there's a little bit of subjectivity here. If you want to be more objective, you can use the Quiros classification scheme, and your cutoffs here are less than 4 millimeters for a shallow cribiform plate, greater than 8 for a deep cribiform plate, but I find that the subjective analysis is usually sufficient. Halar air cells are anterior ethmoid air cells that live between the infundibulum and the orbit. Normally, the infundibulum should be right up against the orbit. If there is a discrete air cell in between the infundibulum and the orbit, that's called a halar cell. Now, these are a normal variant. If they are expanded and compress the infundibulum, then that can cause pathology and is worthy of particular mention. Now, often you'll see a septation in the mastoid air cell, and a little pocket of the mastoid air cell will extend up in between the infundibulum and the orbit. That's not necessarily a halar air cell. A halar air cell is a discrete ethmoid cell, not just a septation, a partial septation of the maxillary sinus. Anode cells are the counterpart to halar cells when we're talking about the sphenoid sinuses. So anode cells are posterior ethmoid air cells that extend superior and lateral to the true sphenoid sinus. Right? These potentially can cause obstruction of the sphenoid sinus, and they may cause confusion to a surgeon who thinks they're in one of these cells when they're actually in the other. So large anode cells should receive particular mention in your report. That's the anode cell. That is the true sphenoid sinus. Agarnesy cells are the most anterior of the anterior ethmoid air cells. Just like the halar cells can compress the osteometal complex, the agarnesy cells have the potential to compress the frontonasal recess. Here is an agarnesy cell. It's got a little bit of mucosal thickening. Evidently, that's bleeding over into the frontonasal recess here because you can see that the frontal sinus is secondarily obstructed. All right, so agarnesy cells are anterior ethmoid air cells that are just lateral to the frontonasal recess. So we've talked about halar cells with respect to the maxillary sinuses, we've talked about agarnesy cells with respect to the frontal sinuses, and we've talked about anode cells with respect to the sphenoid sinuses. A really important concept when you are assessing the nasal cavity is the concept of the nasal cycle. Notice in this picture how thick and robust the inferior turbinate is on this side, actually all of the turbinates on this side, and how relatively atrophic the mucosa looks around the inferior turbinate on the other side. This is normal, and it varies over the course of the day. Some of the day, this will be larger and this will be smaller. Sometimes they'll be about the same size. It varies in an individual patient over the course of the day. That's why sometimes you wake up in the morning and one of your nostrils is stuffed up, and then over the course of the day, that one starts moving air and the other one feels stuffed up. That's the normal nasal cycle, and it's about 6 hours long. I'm going to show you some more pictures of this exact same patient to emphasize the truth of this nasal cycle. Here is the same patient where it's the other way around. Now the left turbinate looks more robust and the right turbinate looks more atrophic. Here's the same patient at a time when they both look pretty robust. Here's the same patient where they both look a little bit atrophied. Normal nasal cycle. At some institutions, the radiologist will administer a sympathomimetic like Afrin in order to minimize the amount of mucosal thickness there is and make it always look like this, more symmetric. People feel like they get a better look at the airways in this manner. I think that this, if you understand the nasal cycle, it's not particularly confusing, and you don't need to do that to all of your patients. The sagittal plane is extremely useful when analyzing the paranasal sinuses. We could have an entire hour-long lecture on subtle uses of the sagittal plane. I'm just going to throw a couple of things out here. The frontal nasal recess is often really well depicted in the sagittal plane, draining the frontal sinus down into the middle meatus. The basal lamella of the middle turbinate, that is the bone that connects the middle turbinate up to the anterior skull base, that is usually very well depicted in the sagittal plane. So a couple of useful things you can see there. There's a lot more we could do with the sagittal plane. So after our discussion of modalities and anatomy, I think the take-home points are that CT is the primary modality for the paranasal sinuses. Conventional radiographs are no longer standard of care, and we should strive to substitute CT. The CT is not a substantially greater dose when you use a low-dose technique, and it provides much more reliable information. Conventional radiographs are both non-sensitive and non-specific. MR has a few niche uses, in particular for infections and for tumors. That concludes part 2 of the lecture on imaging of the paranasal sinuses. In part 3, we'll start talking about pathology.